Hi everyone, so it's 1 o'clock now, so good timing to get started. Um, so first of all, I'd like to welcome everyone to the Children and Young People's Mental Health Advancing Equalities webinar. I'm Antonio Ferrer, I'll be your co-chair alongside Ian Lewis, who is London's Children and Young People's Mental Health Tackling Equalities Working Group and Healthy London Partnerships, Children and Young People's Mental Health Local Authority Advisor. So first things we'll go through just for the first 5 minutes as everyone comes in is the housekeeping rules. If I could have the next slide. So for everyone who's attending as an attendee, can you all just remember to keep your mute buttons on when you join the call and when others are talking? And if possible, try to keep your cameras on so we can all get to know one another. You are also able to use the group chat feature to ask questions or to make comments. At a stage through this webinar, we'll have a panel discussion where hopefully we'll be able to answer some of the attendees' questions to the panel. And also just to make you all aware, the session is being recorded and it will be shared after, so presentations can be circulated. Just lastly, be mindful that there are lots of people with different experiences today in today's meeting with a wide range of views. So just to be accepting and welcoming of everyone. Without any further ado, I'll pass over to my co-chair, Ian.
Thanks very much, Antonio. So my name is Ian Lewis, and I'm the local authority advisor in Healthy London Partnerships Children's Mental Health Team, and I'm the co-chair of the Mental Health Inequalities Working Group, along with Natalie, who's one of the speakers today. Along with Antonio, I'd like to welcome everybody this morning. I think, have we got another slide? Yeah, so this is I think people will have seen this morning's agenda. So the objectives of the session are relatively straightforward. It's an opportunity to think about the importance of tackling inequalities in terms of the delivery of children's mental health services. But primarily it's around learning from each other, hearing from some of our colleagues who have taken forward some thinking about tackling inequalities from the point of view of the provider collaboratives that they're working in. As Antonio was saying, then ideally, as long as we're able to keep the time, there was an opportunity to take questions and have a panel discussion towards the end of this morning's session. So unless there are any questions about the content or the aims, I think it would be good to press ahead. We're a bit ahead of time, which does mean that that's I think probably helpful in giving the speakers enough time to tell us all that they have to share with us. So I think on that point, I'm going to hand you back to Antonio, who's going to speak of his own experiences with relation to children and young people's mental health services. So Antonio.
Thank you, Ian. So, yeah, so as mentioned, I'm a in the lived experience volunteer. So I'm also a mental health ambassador, activist, and speaker. And I'm currently involved with 10 different charities slash organizations. As a young person, I was diagnosed with schizophrenia and emotionally unstable personality disorder, which meant that my mental health journey started as a child going on to young person to young adult. Having started at child adolescent mental health service, it was, I guess, how I was put to people was an unfortunate stage for them, because where this was the beginning of my mental health journey, if they were dealing with my journey now, I feel they would have had a great impact and a much more effective method of dealing with my mental health. I say that because at the time I was going through or just getting to know my mental illness, my psychiatrist would always ask me, what can we do to help you? And of course, coming from a racialized community, one, I'm not so used to opening up, so I wouldn't be given as much as she should have known. And two, to answer that question, having been very oblivious, ignorant, whatever connotation you want to add to it, to mental health, I would always tell her, you are the doctor, you should be telling me what can help me. In fact, going through that journey from a child to a young person to then an adult, I've now noticed that I should have been the one to dictate what would actually help my mental health and my illness. Again, as I mentioned, if they were at the time where I am now, where I have a lot more self-awareness and insight to my own mental illness, I probably would have answered that question with about 2, 3 paragraphs and had my psychiatrist tell me that's enough, slow down, that's enough. My experience in a nutshell, as coming from a racialized community, again, it's difficult, and I always put this to people, it comes from two sides, as a patient and as doctors as well. There's only so much that a doctor can work with so little that you give to them. Simply put, your output matches your input. If you're someone that's willing to share, then there's less room for assumption, as the question goes, for them to assume what works best for you. Whereas if you are willing to share and give as much information of what is going wrong, what is going well, and just in yourself develop that self-awareness, then it's easier to work. As we all know, mental illness is not one that we can just recognize through a brain scan or a blood test. So it all depends on how vocal we are and how much we express our illness or our struggles to whoever is in charge of our care. Unfortunately, coming from a racialized community, there is the tendency to also be over resilient. In that, I mean, I'm okay, I'll deal with it. I don't need your help. I can do it alone. I don't need to tell you anything. You know, this is how I've grown up. I'm a man. I can get through it. There's no need for you for your input. That over resilience becomes a great tendency for racialized communities. And again, to emphasize on how important it is to share, and I guess set boundaries within sharing, but enough to understand what's going on. Picture you have a water bottle, and that water bottle is filled 3/4 with a liquid put in by someone else other than your own liquid. That liquid put in by others is their assumptions based on how little you've given them. If you take out that liquid and put in your own liquid, it gives them the real idea of what you're going through and less room for them to assume what you're going through. With over resilience, you have also the tendency to assume if they're not asking for help, then they're perfectly fine, because we believe, or we have instinct to think, if someone hasn't asked for support, we don't need to offer them support. However, even in offering support, we also have the struggle to accept support. It's all okay to offer support, but to offer something, it has to also be accepted. These are all my experiences as a young person with mental illness from a racialized community. And again, to re-emphasize my first point, if I had my child adolescent mental health service at the stage where I am now, where I accept my mental illness, I accept that I'm a young, Black and schizophrenic male, and I have that self-awareness and insight to what my triggers are, what helps me and what doesn't, then I'm sure my psychiatrist would have loved me a lot more than she did at the time where I was really ignorant and oblivious to my symptoms. I think also the fact that I had that experience, it told me that I should be speaking more about my illness and be expressive in what I'm going through and able to say I need help. A bit early there, but I have no more to go. I'll end up repeating myself over and over again. So I'll pass it back to you, Ian.
Thanks very much, Antonio. Thanks for sharing that, because it's really important for us. And people may have some further questions or thoughts to share with you. I should have said, please do use the chat to make comments and ask questions, and we will be taking those questions as we go forward. So again, thanks very much, Antonio. I'm going to move on to our next speaker, who is Dale Greenwood. And Dale is Dale will, I'm sure Dale will be able to introduce himself, but he's the programme lead for mental health in schools to the East London NHS Foundation Trust. And yeah, so I'll pass you on now to Dale, who can introduce his presentation. I should say I'm going to give for everybody. I'm going to give a 2-minute warning when you've come to when you're sort of towards the end of your presentation, just to keep us on time. Although we actually are well ahead of time, so I'll pass over to you now, Dale. Thanks very much.
Thanks, Ian. So I wanted to kind of stop and just kind of pull out a couple of statements before I go into the presentation. One of them from an event we did recently, turning kind of the findings into our statements that relate to inequalities. And one is a quote from a young person. I want the same chances at life as my peers without adversity or vulnerability. We aren't hard to reach. And Liba said within one of her poems, work with young people rather than against us. And that kind of participation theme you'll see kind of running throughout the presentation. Next slide, please. So I wanted to kind of take a step back in terms of the approach before I get into kind of some examples. So thinking about the difference between equality and equity, and we're very used to kind of offering something equal, which is all well and good for people without adversity, for marginalised, for those that aren't marginalised, those that don't have vulnerabilities. But when you're thinking of those who need more intensive offers or different ways of working, we're putting them at a disadvantage from the get-go. And that you can see on the illustration around kind of reality, even during COVID has made that reality even more kind of extreme. Those that were already vulnerable, those that were marginalised, have been affected and are worse off. Obviously, we can influence kind of the system level and the systemic ways that people are disadvantaged. And we can obviously influence that in every conversation. But what I'm going to kind of think about is kind of how we offer something equitable, how we level that playing field. And our kind of approach to do this and kind of actually achieve transformation is really thinking differently. How do we be critical in our reflection? We've done some great stuff, we've done some stuff that doesn't work, and we need to do better. We need to integrate physical and mental health, but they don't fall in different bodies. It's the same body. How do we work together with different people across the system, thinking about that spectrum of need from universal all the way up to crisis? And thinking about kind of innovation and opportunities. There's so many great stuff out there across the country and internationally that we know works, but we don't adopt them through doing the same and kind of continuing to kind of strengthen the existing system rather than transforming it. And then we won't get anywhere in terms of transformation and innovation if it isn't led and kind of developed by our young people and our families. Well, I as a professional have kind of one opinion, which is lovely, and we know that we don't reach into communities far enough as we need to do. So it's only through co-production and true co-production as well, I'll come on to that in a second, that's how we're going to change something, which you'll see in the kind of fundamentals of trauma-informed practice as well. Next slide, please. So talking about that level of participation, we've gone a long way in mental health from doing to doing with. We've shifted quite well away from consultation and shifted a little bit into collaboration, where we consider kind of young people lived experience as an equal when it comes to service development, improvement, etc., etc. What we're not so good at is devolving power to residents and these young people, and it's only through this we can start to really think about how we address inequalities. How do we really value the assets and employ people to kind of share and influence the decision making and transformation, the way system works moving forward? This is kind of an ambition we want to get to, and there's a number of opportunities across kind of the peer workforce. How do we make the local workforce look and feel like the local population? So recently in June, we held a conference, but we wanted to really kind of flip the way the conference was delivered. Again, shifting the idea that CAMS are the experts, and actually we wanted to hear from everybody else in the system that isn't CAMS. We wanted to hear from young people, parents, GPs, teachers, school nursing. We wanted to hear what we're doing badly. Again, thinking about a kind of critical reflection. And look at identify opportunities where we can work differently to advance kind of what the work that we do. And through 60 breakout rooms, Mentimeters, Jamboards, it was a kind of real impactful kind of session. And now the challenge is now what? Next slides, please. So the now what? So we went away, and with a small task and finish group, we spent a bit of time turning these into actually key messages and themes. But we took it a step further and turned these into I statements. So really personalising what these kind of recommendations were for the ACS, organisations, and education. So the ones related to inequalities, that first one I said around kind of we aren't hard to reach, want the same opportunities. Distribution, I want the same experience and range of support regardless of where I live or go to school. Co-production, I want to be supported to get involved and see changes that I have influenced. I want opportunities to share my insight and become a valuable member of the workforce. Transition, I want to feel like professionals care as I move between different stages of my life. I'm more than happy to share kind of a wider pack as well, if people want to see that, and it goes into the detail for recommendations. Next slide, please. And across the NCL Provider Collaborative, there was a co-produced piece of work to look at the inpatients and kind of what we know around who's admitted, why they're admitted, and kind of some of those circumstances they experience. So we know that from this piece of work, girls are overrepresented, more girls than boys are admitted. White young people are overrepresented, and Asian people are underrepresented. Most of the young people are admitted are from deprived areas. Most of the young people have learning disabilities and autism. Most of those that most of those that have to use the Mental Health Act are Black and Asian males, and a high proportion of those, again, have learning disabilities and autism. The question is, now what? We've got this kind of work which really confirms what we already knew. But this kind of the provider collaborative will be thinking kind of what to do next. So with young people, with parents, how do we create intensive pathways or safe spaces that aren't A&Es, or kind of looking for those collaborations with voluntary community sector organisations way before they're at risk of admission. So yeah, the next stage for us is what next? And next slide, please. And some of the other pieces of work that's ongoing, we've just recently started thinking about our offer for trans and gender questioning young people, thinking about kind of their experience of GIDS, of CAMS. There's a lot of work to do to balance that inequity. So working with young people already known to CAMS, we're going to connect with voluntary sector organisations who support young people in this way to look what CAMS need to be doing and how they need to be working differently. The schools, we need to be thinking kind of, again, identifying those cohorts that are more vulnerable and how do we work harder to reach them and support them. Thinking about young carers, those who are kind of care experienced, those that are unaccompanied asylum seekers as well. And thinking how we support the inclusion and shifting the school culture away from punitive measures to supportive and opportunities to engage and intervene. And then the workforce, as mentioned, how do we make the workforce more reflective of the local population? How do we make a traditional CAMS, kind of very academic driven. How do we transform that into make sure that the local people have opportunities to get in to be part of that workforce? So thinking about the peer support workforce, how do we utilise accreditation schemes from HEE, Royal Society of Public Health? How do we utilise these locally to start kind of changing the way services look and feel? On the digital aspect, we've just employed a free digital participation leads who are young people themselves, and their whole purpose is to understand how young people want to interact and kind of receive communications about mental health. So thinking about how we admit that we're not relevant anymore on Facebook and Twitter and move with the times and get to TikTok and Snapchat and Instagram, if that's what young people want and how they want to use it. Social prescribing is a huge way of thinking about inequalities as well. How do we, again, think about relevance? What's relevant and kind of interesting for young people is not going to be what's kind of relevant to decision makers. How do we kind of make sure the offer is diverse, it is accessible, and where there's barriers such as finances or that initial hand-holding, how do we make sure we can support everybody to access social prescribing, not just those who have it easier? And then thinking about trauma-informed systems, how do we collaborate, work differently, see behaviour as communication in schools, in organisations, within kind of our police partnerships? How will we change that? And I will stop there.
Thanks very much, Dale. Our next speaker is Jackie, but Jackie is not available until 1:30, so we do actually have some time for some questions. I mean, I must say, Dale, I thought the opening screen sort of reminding us of the difference between equality and equity and justice was it's a really powerful image, and because I think that it's really helpful way of thinking about it. So we've got one question at the moment in the chat that I can see, and it's for Antonio. So Antonio, Nadia asked about whether your thoughts about allowing more creative outlets to sharing how individuals are feeling if people don't feel they've got the words to express their feelings.
Yeah, absolutely.
Sorry, it was for Antonio.
Oh, sorry.
I'll bring you in afterwards.
No worries. We can share that answer if you want. I'm happy to share that answer. No worries. I guess for me, I'd say it's definitely something to consider. I think it actually goes without saying, and if people don't have the right words to express themselves, and how else do we get them to express themselves? We can't force an answer out of them, but I guess we can give them alternatives to expressing themselves. And as someone who spent time in the mental health ward, we had group therapy where we used different methods of expressing ourselves. We had music therapy, art therapy, and these things, at a glance you think no, they're not going to help. They mean nothing. Like what kind of I'm not even an arts person. I prefer football. But when you give them a go, you come to find that there are sort of hidden admirations in these methods that you obviously, as someone, as I mentioned, is over resilient, you don't even give a thought to. But as you go to try them out, you come to discover actually this is a lot easier than having to find the words, or having to find the exact words that show how I'm feeling. I know for me, as someone who does a lot of podcasts and speaking opportunities, I believe those creative outlets have actually shaped how much I'm able to illustrate how I'm feeling through analogies and sort of examples. Like, as I mentioned with the water bottle example, those have really opened my way of expressions, and it's not so much always technical terms or technical words. It's actually giving you this analogy of what is going on in my mind. It helps a lot better than what words actually will come out of my mouth. And working with different therapists, I've actually found that sometimes, especially there was one therapist I found where she was in the nicest way possible. She wasn't interested in the words I had to give her. She was actually interested in how I could illustrate how I was feeling to her. So there's definitely scope for that. And Derek, if there's anything you want to add on to that.
Yeah, just thinking about a couple of examples that bring that to life. So I know COOF have an area where they can post their own kind of pieces of artwork or creative writing. There's a couple of examples where the Tree of Life narrative therapy is being used to really tease out someone's identity and their story, again, kind of through kind of creative arts. I'm thinking about kind of, again, coming back to that social prescribing. Talking therapy is great for what, 40% of people, I think it is. But how do we use dance, art, music making, kind of podcasting as something that we encourage people to do and express themselves through that? And how do we facilitate so people know about the options as well? There's the options are there, they're readily available, but where do we advertise them? And then thinking about kind of a role in schools, how do we think differently? How do we move away from the mental health workforce being a doctor, a nurse, a psychologist? How do we get creative therapists in there to work differently for different people, so people have a choice of which support mechanism they want?
Rhiannon's made a point in the chat around whether this is boys or I find it more difficult to find the right words than girls. I'm sure that's not universal, but I'm wondering whether it's more difficult to recognise mental health issues in boys because of that that sort of communication, a difficulty in sort of communicating their feelings.
I imagine that is the case, but if we go through transformation kind of change and we're constantly kind of engage our young people, we have young people employed, we're going to get the insight to offer a selection of support rather than just one that suits kind of one group. So thinking about if a young boy didn't want to talk, they had the opportunity to go to talking therapies, that might not work, do digital counselling or do social prescribing. It's about kind of creating that system where they get to choose according to preference and need, not just what's available.
Thanks, Dale. I've noticed an earlier comment from Kilna around mental health offers, and this isn't necessarily a question to anybody specific, but people had thoughts about this, but the difficulties in getting a mental health offer for children with special educational needs or disability. And I don't know whether anybody's got any thoughts about that group that they would like to share and the difficulties in giving them mental health support.
Ian, that was the question I was going to ask Dale about the inpatient situation in currently with higher proportions of children with learning disabilities. So I'm interested to know what does that tell us about the system?
For me personally, again, I'm going back to I only have one opinion and perspective. It tells me that there isn't those opportunities within that early intervention space for children with learning disabilities or autism to kind of respond and get the support they need kind of within themselves and kind of as part of the family. And I found that actually quite wider systemic issues around, thinking about housing as well. Somebody with autism, with sharing a bedroom with two siblings who don't have that space to kind of de-stress and kind of manage their own, regulate their own emotions. But it's thinking about kind of what are we doing wrong in the community? Why do young people with ASD and learning disabilities have to go firstly to A&E, which is a very overstimulating scenario in itself, but why have they ended up in hospital? What are we doing wrong? How can we work differently? Thinking about your positive behaviour support plans, your functional assessments to understand how we can better to support them to stay at home with their families.
And the answer?
Money, early intervention, different ways of working. There's some great learning from families who've been through the system. And again, like I will go back to co-production, I have one opinion. We need to hear from the families that have experienced this, the young people that have been put under the Mental Health Act and received care, which is kind of created for mental health, not necessarily autism or learning disability friendly as well.
Thank you.
Mitchell, I thought I'd probably add some of the difficulties that there are in working with children's social care, and the lack of provision for. I think there's a general lack of provision for children with a variety of complex needs, but I think that's often true for, particularly so for children with learning disability and autism, and also many of the young people that are in care and sometimes within the youth justice system will have an undiagnosed or unrecognised learning disability or an undiagnosed autistic diagnosis or other neurodevelopment condition that just haven't been seen in their early life, and it's so I think that there is a lack of community provision, which sometimes leads to these young people being in hospital in an inpatient setting when that's quite likely not the right thing for them. Erica, I'm not sure whether Jackie has joined us. Do we know?
No, I don't think she has yet. I will let you know when she has, but I think there's another question in the chat. Sorry, Natalie, were you going to say something?
You're on mute, Natalie.
I'm quite happy to go before Jackie, if that helps.
She mentioned that she wanted to, yeah.
Okay.
Yeah.
All right. Okay, I will try and see if I can find she is. But to that question, I've put it in the chat. But I think the inequalities that we are seeing, both for disabled and racialized, and the intersection of race and disability is an indication of our ableist and racist kind of society and structures in which young people and their families are having to navigate.
Yeah, and how do we shift to a place where a young person and family tells their story once and then the system finds?
And I think there's also something about that I think that there is work for the system to do to actually start kind of being curious and exploring children and young people's experiences through that structural lens, because I think the onus is often on groups who are minoritized to always keep telling their, as you're saying, keep telling their story, keep sort of sharing, their distress and the difficulties that they might be experiencing. And I think that obviously you don't want to arrive at assumptions, but I think that kind of having that in your mind around, some of these things will be structural, and our response to those may be wider than just within our service. Because if all we're doing is focusing on, what we can do, within our boundaries, it means that we won't necessarily be as integrated as we possibly can be, and to provide the best support for families.
Yeah, and I think it's only through that integration and kind of collaboration with health, social care, voluntary sector organisations, education, we can do that. And when I think about co-production, I don't just mean service users. I'm thinking again of wider groups of people, kind of your citizens' assemblies, your youth clubs, and getting their voice from the population, not just those that have been known to CAMHS.
So I'm just conscious that Jackie hasn't joined us, and I think, Natalie, it's probably best if we take up your offer to go next, and then when Jackie joins us, she can do that. Is that okay? And I don't know if Fatia, we can bring up the slides. Or Natalie, you're not working the slides, are you? Oh, yes, you are. Apologies. So I think Antonio is charged with giving you a 2-minute warning.
Remind me how long I've got?
10 minutes.
10 minutes. I'll be on your back for the last 2 minutes.
Okay, super. So hi, my name's Natalie. I'm the Programme Delivery Director for Black Thrive in Lambeth. Black Thrive is a systems change initiative, and our focus is on addressing the inequalities, in particular around mental health, that are experienced by Black communities in Lambeth. If I can have the next slide, please. So I'm here, I guess, to kind of talk about a project. So broadly, our work focuses on placing the voices of communities at the centre of decision making. We sort of I describe ourselves as like the PA to a partnership, probably a bit like the bullying PA, not necessarily, but we are like the pain, the PA that is a real pain in terms of trying to get the partnership to be where it needs to be, essentially. And so our partnership is made up of the local authority, the CCG, Metropolitan Police, South London and Maudsley Trust, and we also have voluntary sector representation and individuals in the community who are kind of quite active. And a lot of our work is around kind of influencing policy and practice, and kind of testing and developing interventions. And so I'm talking today about a project that we did quite early on, when I've been in post coming up to 3 years now, but it was one of the early projects that we did. And I don't need to kind of go over the inequalities that in particular young Black men experience in relation to their mental well-being. So and I'm going to sort of tell a little bit of a story. So the public health team wanted to commission some work to address the inequalities that young Black men experience. And so they were in conversation with South London and Maudsley's engagement team around that time. And so they were about to kind of commission what was looking like a toolkit. And I was kind of like, hang on a minute. Who said young Black men wanted a toolkit? Like, who did anybody ask? All I said, I know I don't want a toolkit, but, you know, has anybody asked if that's something that people want or need? Or is that like the most relevant response? It makes us look busy. We can demonstrate that we've produced something, but how effective is it going to be in reality? And so I pushed quite hard, actually, to say, well, I kind of think before we develop an intervention, let's actually ask the question, like, you know, what would be helpful? And so eventually, after twisting arms, you know, there was an agreement to do that. And I have to say that the team from South London and Maudsley, so this work was led by Chanel Myrie, Taiwo Aziz from South London and Maudsley, and within my team, it was Siddiqui Harris and Nathan Lewis. So I am sharing their work, essentially. And so what we wanted to do was to kind of find out about how Black men talk about themselves, and how this therefore influences their understanding of their own well-being, to kind of get a sense of how professionals talk about well-being and mental health and how that might influence their practice, and what sorts of interventions young Black men themselves thought might be useful in terms of supporting their mental well-being. So I can have the next slide, please. So the kind of process took place in sort of 3 phases, and we are now kind of going to be moving into the intervention design phase. But to start with, we did some interviews and focus groups, both with young Black men and with professionals. And then through that process, we identified kind of interventions that were kind of put forward. And then we asked people more widely in the community to essentially vote on the interventions that they felt would be most appropriate for them. Could I have the next slide? So I thought I would just share some of the themes that came out. I mean, there were loads, and there were kind of themes around like the impact of kind of narratives around masculinity and how that can influence kind of help seeking. But I kind of feel like that's, I think, quite well known. And so I didn't want to exhaust it today. So one of the things that kind of came up for us was around, well, not for us in terms of the work, was around the need for safe spaces and that ability to relate. And this also kind of reflects some of the work that has also been done by, I think it's Professor Keating, Frank Keating, where, you know, his work with Black men have highlighted like the importance of sharing similar social identities to your therapist or to the clinician, and having that opportunity to feel like somebody relates to you because of those shared understandings. And so that was something that came through very strongly in this. It was that people wanted to speak to somebody who looked like them. And obviously this is not necessarily going to be applicable to everyone, but I suppose when we think about it in the context of what the workforce looks like, in the context of you know, the NHS, actually there's a huge underrepresentation of Black therapists, and in particular the underrepresentation of Black male therapists as well. So I think that that's just something for us, I think, to kind of bear in mind, because again, this is another structural issue. Go to the next slide, please. The other aspect was about authenticity and being able to be your authentic self. And so part of our work also engaged with young Black men who identified as gay and bisexual. It was open to people who identified as trans, but we didn't manage to engage with anybody who shared that identity. And again, again, that kind of came through the need, seeing the importance of sharing sharing similar identities, that people would also be able to relate to you. Could I have the next slide, please? And so I think, and again, this shouldn't be a surprise, but I thought rather than framing it as a lack of trust in services, I think one of the things that I think when we're thinking about like narratives around people, kind of communities and their help seeking, that this lack of trust of institutions actually isn't a kind of figment of their imagination, and that actually that is also embedded in the experiences of people that people know, they're the people that they care for having experience, but also having quite high, I mean, particularly in the context of our work, having quite high profile cases where people have actually lost their lives as a result of poor practice. So again, this being a kind of challenge and barrier to engagement. If I could have the next slide, please. So the second part was around kind of looking at like interventions. And so we had about 88 people kind of log on, but what was quite interesting that not everybody kind of voted. So that could be an indication that perhaps what was suggested wasn't of interest, but we actually don't know why that is. But I think one of the things that was quite interesting was the high proportion of people, young Black men, who actually, suggested that individual therapy, if they were going to invest in an intervention, that it would be therapy.
No,
and I think,
sorry to interrupt, this is just your 2-minute warning.
Yeah, I've literally got, I think, one more slide. Go for the next slide. So I guess the key learning for us was really that it's so important to actually start with the communities that you're trying to work with. And for us, it was obviously working with young Black men. And I think for us, there was this whole notion, this kind of narrative that Black men don't want to access therapy. But I think through the work that we did, that actually wasn't the case for many of the men who we were engaging with. I think what's really important is that when doing this work and thinking about co-producing, it's really important to engage with Black-led organisations, and particularly if you're working with Black, around Black communities who are actually rooted in the communities, because then you get an opportunity to engage with people who you wouldn't ordinarily kind of come across. And then I think there is also something about the use of design. So we kind of played around with it before, played around with it so that it didn't necessarily feel like it was something that was coming from a medical institution, and they kind of gave us the freedom to be able to do that. And I think the other thing for us was from some of the other kind of work that we've been involved in, or some of our partners, I think it's really important for us to think about the privilege that comes with our social identities and what that means in terms of how people show up, when you're calling them to engage in co-production activities, and that kind of, for us, in terms of having that proximity, because we kind of were quite deliberate in ensuring that people who were largely interfacing with the young black men we were working with were predominantly, not so young, but youngish in comparison to my team. That in the team that they were young, but that that we would have young black men who were also kind of working with young men, and I think that enabled us to surface insights that we perhaps wouldn't have ordinarily. So I just think that for us, that is something that we kind of are tend to be quite deliberate when it comes to thinking about how and who we're co-designing with. And I think that's the end of my presentation.
Amazing. Thank you so much, Natalie. That was very insightful, actually, and I agree. And although it was insightful, it was actually quite heartbreaking to hear some of the facts in that as well. And a little footnote, I'm a very big fan of Black 5 too. Without further ado, then we'll move on to our next speaker, who's been able to join us now. I'd like to introduce you guys to Jackie Dyer, who is the Mental Health Equalities Advisor for NHS England and Improvement and Co-Chair of Thrive London and Black Thrive. Jackie will be sharing an overview of what cultural competency means and highlight culturally competent emulation for young people in London. I'm aware you might not have as much time as we have allocated you, Jackie, but do feel free to speak for as long as you can.
Thank you, Antonio, and really happy to be here. Sorry for the delay. But I think in a way that Natalie has spoken to what developing culturally is of actually developing culturally competent services through co-production actually can have tangible outcomes of being inclusive in the process to create services that are much more responsive to the population that's being served. So how, in a way, sort of nationally and regionally, there is a policy sort of framework to encourage the system at every level to pay better attention and activity to do the work in this way is actually the patient and carer race equality framework. So my role as mental health equalities advisor for NHS England and for Health Education England, and I was also involved in the Mental Health Act review and co-chaired a subgroup of that Mental Health Act review, which focused on the African and Caribbean experience. And out of that emerged two particular recommendations. I'm sure many of you know that the differential outcomes, the disproportionate experience of people from racialized groups, particularly Black people, is historically very, very, very poor. And this has been known for decades, quite frankly. And we continue to describe the situation without being very proactive in any way to attend to changing that trajectory. And in its worst form, like Olaseni Lewis, actually we lose lives. Black people get killed in care. Supposedly, care when they are experiencing their most vulnerabilities. It's really quite shocking. So the two key recommendations that emerged from the Mental Health Act review to help to attend to this, and the catalyst for the Mental Health Act review was to actually attend to the different experience of racialized groups overrepresented in inpatient settings, and the rising levels of detention under the Mental Health Act. The two recommendations are the culturally appropriate advocacy, of which I would love to see what does that look like for children and young people, and the patient and carer race equality framework. So at NHS England, we have, as a result of the 5-year forward view for mental health, of which I co-chaired, which now became the long-term plan for mental health, there's an underlying emphasis of addressing inequalities and inequities, and that is couched within the Advancing Mental Health Equalities strategy, and leadership for that is via the Advancing Mental Health Equalities Task Force, which I chair. I also chair the development of the Pcref framework, short the acronym for Patient and Carer Race Equality Framework, steering group, which sits within the task force and the governance of NHS England. So the Advancing Mental Health Equalities strategy, published October 2020, has 3 key work streams. 1, helping local health systems to improve, of which the Pcref sits within that. 2, improving data and intelligence, so that we are not just operating off of anecdotes, but we are making intelligent decisions based on data and research, and the stories of the people that we're serving, to actually then inform resource flows. And third, around the workforce. And so to attend to the Pcref, there are 3 key components of the Pcref, and this is essentially an accountability framework, a systematic accountability framework to drive forward improving mental health service provision in a way that meets the needs of racialized communities. And it will be rolled out next year, and we're busy working on the development of that framework with the help of our pilot sites and lived experts by experience, service users, carers and communities. There are 4 pilot sites: South London and Morley, East London Mental Health Trust, Birmingham and Solihull, and Greater Manchester. And the components of the Pcref framework, 3 areas. 1 is statutory and regulatory obligations. So the Care Act, the Equality Act, the Mental Health Act, the Use of Force Act. How are these manifesting in a way that are advancing, that are improving outcomes for racialized communities? And we're involved with the CQC in helping them to develop, both from an equalities perspective and in terms of the Pcref, how they better monitor and assess in all of their regulatory functions mental health service provision across the piece, in terms of these issues, and in terms of implementing this framework and their Advancing Mental Health Equalities agenda. So what's the narrative, what's the evidence that progress is being made along these lines? And that's really very pertinent to children and young people. The second part of the framework is the organisational competencies, and very much Natalie spoke to some of the key organisational competencies, which through our collaborative and co-productive way of developing the framework, some of the key competencies are co-production, cultural awareness, partnerships, data and intelligence, leadership and governance, among a few others. And I think we've landed on about 6 key organisational competencies that will be signed off in terms of when we publish the roll out the framework next year. And the third and most, I think, the most important third part is the patient and carer race equality feedback mechanism, and that comprises of 2 things. 1 is we're developing a sort of digital tool to help to get feedback in real time about whether or not service users, community members, carers are experiencing improved services from a racialized perspective, and 2, to agree on a series of key metrics that will be monitoring progress around improving the racialized experience of mental health service provision. So this will apply across from the cradle to the grave in terms of all mental health services. So children and young people, adults of working age, older adults, IAP services, children and young people services, CAM services, inpatient services, forensic services, perinatal services, the whole shebang, right? Is how are we using the framework to improve the racialized experience, essentially. And that's really
Jackie, you've got 2 minutes.
Lovely. And that's where I want to end, in a sense, is to kind of encourage you to embrace what is essentially a major lever for equality improvement, for quality improvement, that is both couched in the new Mental Health Act. So it will be in the Code of Practice, as well as being owned from nationally, regionally, all the way locally. And how is the children and young persons agenda actually using these opportunities to transform the access, the experience, and the outcomes for racialized communities in a way that's never been done before, because what's been done today hasn't worked. We're still terrified, quite frankly, of mental health services, because in our experience as racialized groups, if we go enter them, and predominantly we end up, especially Black people, at the point of crisis, that they're going to kill us, that we're going to die. And we need to change that trajectory, change that narrative. And I think that what we've done in some of the work from Black Thrive's perspective is actually show how that can be done. Thank you.
Thank you, Jackie. That's amazing. I'm literally blown away by the work you're doing. You're a literal superhero. But as a wise lady once told me, even superheroes need to recharge. So please don't forget to take a break with all the work that you're doing too. Moving on to our next speaker, and I'd like to introduce everyone to Nana and Daphne. Nana is the head of Children and Young People Services and Mental Health Support team clinical lead at Hammersmith, Fulham, Ealing and Hounslow Mine. Daphne, who is the school's mental health practitioner at Hammersmith, Fulham, Ealing and Hounslow Mine, will both be sharing a snapshot overview of some of the pilots being delivered by Hammersmith, Fulham, Ealing and Hounslow Mine.
Thank you, Antonio. Just to say, Jackie, Natalie, I'm a fan of Thrive London, Black Thrive, and been following you for a while, doing amazing work. I'm really looking forward to the work evolving. So I'm Nana, as Antonia introduced me, and Daphne, do you want to introduce me?
Everybody, I'm Daphne.
Thank you. So go to the next slide. So we're from Mind in Hammersmith, Fulham, Ealing and Hounslow. So Mind, many of you will know, Mind is a leading mental health charity in England and Wales that provides advice and support to empower anyone experiencing mental health problems, and campaign and to improve services and raise awareness and promote understanding. So there is national Mind and our local minds. We are one of 25 local minds across England and Wales, and each mind is unique in its way, where they are based and embed themselves within the community and tailor our services to match the needs of the community. So some of our services within Hammersmith, Fulham, Ealing and Hounslow Mind are both clinical, non-clinical and social prescribing services, where we provide, we've got a crisis service within our adult services, and we have a transition services for children of that transition age group, and we have a well at work service. In 2019, we were successful as being part of the pilot site for the Trailblazer mental health support teams. And that's key in terms of what I'm going to talk about today. So what we've going to give you a quick snapshot of some of the pilot projects that we, as HFEH Mind, have undertaken under our mental health support team and under some of our existing projects to support in terms of addressing some of the health inequalities within our local community. Can we go into the next slide, please? So one of the first projects that we've undertaken as part of the mental health support team, we have across our mental health support teams, we're working across roughly around 54 to 55 schools, and out of those schools we have some which are special educational needs, and we have 2 pupil referral units. So pupil referral units, for most of you who knows, for children who've been excluded. And so one of the issues with the pupil referral units, we were not getting any referrals at all from the pupil referral units. And a lot of the young people and staff explained that the young people within the pupil referral unit did not want to engage with mental health services. So we started doing some focus groups, and based on data and research and communications with our local service users, one of our systemic lead practitioners, Natalie, developed and designed our education inclusion pilot program. So do you want to go on the next slide, please? Next slide. So I'll start speaking anyway. So the education inclusion program provides support to address social inequalities and traumatic experiences for children and young people who are based in the PRUs. And the majority of children and young people who are placed in PRUs were impacted by complex trauma and social inequalities, which prevented them from accessing mental health support. And a lot of the young people expressed that they distrust, and they felt there was a lack of cultural awareness in statutory services, and they felt rejected by the school support systems that led up to their exclusions. So there again, another traumatic experience for them, being let down by the systems that are there to support them. And then, so prior to creating the education inclusion program under our mental health support teams, we had, as I said, literally no referrals, but since we created this program to date, we've had a total of 8 referrals. Then we thought about things around the prevention and early intervention around this. So what are we doing around preventing children from getting to that point where they are excluded and needing to go to pupil referral units? So we worked with 2 pilot schools and did a pilot with 27 children at risk of exclusion. So 27 children participated in the education inclusion program between this year, April and July. The education inclusion program supported children and young people to engage, children and young people who are exhibiting persistent, disruptive, challenging behavior to engage in a program where looking at how it was impacting in their academic attainment. The program also provided prompt access, and that is key around early intervention, the prompt access to education whilst avoiding the negative trajectory that often accompanies schools' exclusions. And the program included student workshops, one-to-one sessions with staff and pupils, ensuring that we're not placing the problem in the child, but also doing workshops with teaching staff. And then also exploring adjustments and policies within the schools, which were contributing to some of the social inequalities. So some of the behavioural policies and plans that schools had in place, we needed to do a review and look at them and think about how they were contributing to some of the inequalities. So using a trauma-informed approach to intervention for children and young people, the education inclusion programme did have an overall impact of improvement of 96% and prevented these children from being excluded. Some of the training included staff training around trauma-informed behaviour management, and this resulted in better understanding of empathy and positive interactions with children and young people, which decreased the risk of exclusion caused by social inequalities. I said this is a real whistle-stop tour. There's just so much to this project in itself, which I can share later on. Can we go on the next slide, please? Then looking at our data from mental health support teams across our West London and Hammersmith and Fulham mental health support team, we saw that we had particular schools, quite a few schools, which had a high population of children and young people from South Asian communities. However, we noticed there was literally 0 to just maybe 1 or 2 referrals coming into the service. And so two of the EMHP set out to do an audit and focus groups with children, young people, families, and with staff to look at where the barrier was. And can we go to the next one? Next slide, please. And so from the research, in terms of the mental health need, I mean, I'm not going to go into a lot of data because, I mean, lots of this is commonly known and is out there, but just to highlight the taboo, the issue around taboo, most of the communities hide it due to shame and reputation. And then 80% of Sikh women and 68% of Sikh men knew someone in the community with poor mental health. And then from the young people, there was a fear, and their families, a fear of professionals being judgmental and making assumptions and not understanding their cultural values and their religious belief. And religion played a big factor in this, in our research as well. So do you want to go into the next slide, please? So in terms of this program, this pilot program we are about to, we're currently working on, which is called Chai and Chat. The idea is to work with parents, because when we looked at some of the referrals that did come through, one of the problems, especially with the primary school age children, parents were not consenting to their children accessing support from our services. And so, as I said, through the focus group, it was around stigma and trust of the system. So 2 of the EMHPs, along with a senior clinician, are working on a program called Chai and Chat. So we do have parent coffee mornings. So in the South Asian community, from their research and our service user groups, it was thought that actually if we do something targeted at South Asian community families, parents, called Chai and Chat, where we have parent coffee mornings to talk about the stigma and utilizing some of the temples, mosques and the religious communities to support us to engage the families, to build up that engagement and that trust in the system, to build up, to increase referrals and to get the families to engage in services to actually support in proper early intervention prevention of mental health and increase parental engagement. I mean, just in terms of doing the focus groups already has increased engagement before we've actually started the pilot project. So it speaks a lot to around, if you talk to the communities and the people they trust, actually that would improve engagement in services. Next slide, please. Yes, so the Chai and Chat program will be one-off workshops followed by a 4-week program focusing on the impact of mental health, the impact that mental health has on children academically, socially, mentally, and physically. And we will start the pilot program focusing on 2 of our schools with the highest population of South Asian backgrounds. Then going to go into the next one.
Nana, you've got 2 minutes.
Great, Daphne.
Okay, over to me. I'll try and be as brief as possible. So I'll explain a pilot project that we provisionally named the Black Boys Project. However, the young boys recruited will be surveyed and then they'll give the project its final name. Could we go to the next slide, please? On this slide, you've got a bit of information about the project and rationale behind it. I'm not going to go through some data, but there are different reasons for the difference in prevalence of mental health conditions amongst boys from a Black, African and Caribbean background. And when developing this project, we really wanted to focus on what happens to the boys during adolescence, because we found out that there are lower levels of diagnosable mental health difficulties in boys at the age of 11 compared to white or mixed heritage boys. But adult men from an African and Caribbean background are significantly more likely to be detained under the Mental Health Act. So we were thinking about what works well in regards to interventions with Black boys and the strengths of other programs and other forms of informal mentoring support. And what we found out that was what was integral was building that trusting relationship with professionals And this relies greatly on representation and cultural competency. So in the project, we've got a small group of boys who will receive guided self-help intervention with a school's mental health practitioner, and then they'll have support from a therapeutic mentor who is from the same ethnic background as the boy. So, and he'll sort of tie in with the family, the young person and the school to ensure that the guided self-help strategies will be implemented in all aspects of the young person's life. Next slide, please. So now talk very briefly about the focus group that we conducted in June with a colleague of mine. And we just tried to find out more about the young person and their perspective and experience of mental health and how they felt about accessing mental health support. And I've picked a couple of key comments and themes that we picked out from the focus group that we conducted. So in light pink, you'll see a bit more about the boys' personal experience, and they discussed about how their culture has impacted their perspective of mental health. You'll also see other comments in lilac, where the boys spoke about barriers to accessing mental health support, so pressures to be a man, that sort of thing. And then in dark pink, you'll see what the boys would like when accessing mental health support. So they did say that they would like support from someone that they can relate to of the same ethnicity, which is why this mentor, this therapeutic mentor, will be from the same community from the boys. So next steps in regards to the this pilot project that we're putting together. At the moment, we're currently on the stage where we are recruiting a therapeutic mentor that will be with these boys, informally, sort of, like I said, re-emphasising the guided self-help strategies, and the boys are helping us in recruiting an appropriate mentor with them. So once we're currently at that stage, and then once it's done, we'll conduct this intervention where they'll have guided self-help with a school's mental health practitioner, and that will be supplemented with the informal support from a mentor. That's very brief, but I'll hand it over to Nana.
I'm sure time is up, so I'm just going to quickly end now.
I'm afraid so.
Sorry?
Go ahead. Give us have another 30 seconds to a minute. Go on.
30 seconds. All right. What are these slides are going to be shared, but I mean, I mentioned that at Mind we campaign as well, and campaigning is vital part of creating awareness and challenging stigma. And one of the campaigns we did this year, which was a campaign we launched on the 1 year on from George Floyd's murder, we partnered with Sifas Williams, a campaigner, and did a campaign with young people, 9 boys, but there's only 8 in this picture because one of them didn't want their pictures to be seen, but they took part in the workshop where they did a whole day workshop on a Saturday about the world they want to see. And I will share the link for anyone to go and look at and read the letters that these boys wrote. I'll be honest with you, the workshop was meant to be about the world they want to see and around the impact that George Floyd's death had on them, and the whole Black Lives Matter campaigning that was happening. However, I can tell you about 60% of the session turned into these young boys talking about the inequalities and injustice they felt they felt in the classrooms. It was quite emotive what was coming out from the sessions. We'll talk, maybe we'll share the link to some of the snippets of that. As you can see, I've put a quote there from one of the boys from a small part of their letter, that they don't want to go to a shop and worry about taking a receipt just in case they accuse me of stealing. And I've gone over my 30 seconds, but I want to leave the last word to one of the young boys that was in the group. If we can go to the clip.
Not hearing any sound.
I don't think the sound has been shared. Might have to reshare the screen and share the sound again.
As a Black British boy, I found my skin colour a big part of my identity. As a Black British boy, I found my skin colour a big part of my identity, only because of the people around me. In my area, I feel like my identity is slightly degraded, as sometimes people's attitude and reactions towards me is a bit shocking. For example, they give me dirty looks or they don't say thank you for something I've done. I'm not a bad person, and I'm respectful of people no matter what their colour is. I don't judge anyone, but it still happens. This makes me upset.
I thought I'll just leave the final word to a young person, because this just shows and highlights the importance of the work, that everything that has been spoken about just to this point now, why it's important. And I'm just going to leave it there and say thank you. And as part of Mind's vision, we won't give up until everybody experiencing a mental health problem gets the support and respect they need. And that's why, in terms of partnership and talking, sharing, learning is really key. Thank you.
Thanks very much, Nana. And yeah, you managed to extend your 30 seconds by giving it to the young person who couldn't be denied his moments. So thank you for that. It was well worth it. We have overrun a bit. I think there've been a couple of specific questions for you, Nana and Daphne, around whether all of that was provided through the MHST or whether it's part of a wider Minds program.
It's part of it is part of the mental health support teams, and then some of our other programs is part of the wider Mind program, which they've been delivering pre-mental health support team and just expanding on.
Thanks, Nana. Has anybody got a very quick question? Because then, and then after that, I'm going to go to each of the panel members just to give a last sort of reflection. But has anybody got any? I'm conscious there's been a huge amount of conversation in the chat, which has been really helpful. I don't know whether anybody wants to sort of develop. Esther, you've got your hand up.
Yes, hello. Hi, I'm Esther. I'm the clinical bed manager for the Northwest London Collaborative. I have wonderful project which I'm actually hearing and loads of stuff that's taking place. But what I like to put across, because I'm going to use what I normally call critical realism, in the sense that all this is fine, all plans and everything that we have in place. But in the meantime, what do we do? Because as a clinical bed manager, I see inequalities, health inequalities on a daily basis. And what I'm noticing is that people of Black and ethnic minority right now, we're just dancing between the raindrops. Things that we can actually put in place, i.e., for example, if a young Black or Black and ethnic minority person is picked up by the police, they're taken on a 136 into the cells. Why don't we have someone who is an appropriate adult, who is of the same ethnicity, that could actually advocate for these young people? I have actually seen, and even myself, because I've worked in numerous countries, I've worked in America and different parts of the world, and inequality is still quite ripe, in the sense that it was highlighted during COVID and still being highlighted, and government talks about the leveling up project, which I haven't seen anything being done as to date. I'm not trying to be negative, but I think more should be put in place. Yes, we have all these nice guidelines and policies and things that we're planning on doing. But the question is, do we have a timeline as to when it will be achieved and when we would be heard? That's the question I would like to ask to the panel, or put to the panel.
Thanks, Esther. I've seen Natalie's hand up.
Yeah, I mean, what you said, Esther, like really resonates with me. And I mean, hopefully you'd be encouraged to know that the review of the Mental Health Act, one of the recommendations is around providing culturally appropriate peer support and advocacy. And one of the things that, so we're kind of working with the Department of Health and Social Care, I suppose, around, I suppose, making them aware of the importance of the people providing the support also sharing similar social identities, whether that be your race, whether it be your sexual orientation. So that hopefully should be coming, coming down. And they've recently put out a tender that just closed, looking at pilots to kind of fund pilot projects, not for very long, unfortunately, but nonetheless, there should be some learning. So hopefully that will start. And I think people are doing pockets of work. So at Black Thrive, we've just co-designed a peer support and advocacy service that will be launching hopefully at the end of November, beginning of December. And a key focus for us for that pilot, which is 12 months, is around gathering like the evidence base for what works, what doesn't, so that we can share that with others, because what you said is really important.
Thanks, Natalie. Yeah, I mean, I think your points are really important, Esther. I don't think, it's an illustration of why it is vital that we continue this work, and it has to take place at a structural level and at the level of strategy, and also at the level of the individual practice and what individuals experience when they come into contact with health services and mental health services in particular is what we're talking about today. But I don't think it's negative. I think it's realistic that and that we should be angry about it. I'm conscious of time, so I think the idea was to go to each of the panel members and just give a reflection on, and I'm going to ask you to sort of think about, if you had one wish, what would your hope be for mental health services? And shall I start with Natalie?
The services to stop being so racist. But I think actually at the very least, kind of being able to recognise that this is a thing, that it does affect the way in which people are able to access services, experience them and their outcomes, and to be able to be comfortable with having those conversations, but most importantly, acting on the kind of intelligence that you're gathering from the people who are experiencing these inequalities and really moving that forward.
Thanks, Natalie. I haven't got a particular order on this, but Dale?
For me, I think it'd be an offer, not a kind of team, that is co-designed and kind of co-delivered with young people without the thresholds that are kind of currently in place in a barrier at the moment.
Nana?
More improved way of how data is collected and used, because data is only as good as the people who will respond to it. And a lot of the people we're talking about today, marginalized groups, people facing inequalities, the poor communities, SEND communities, we're not getting that data. So how are we collecting that intelligence to really design and deliver appropriate services? And one last thing is about statutory services and voluntary sector services working more closely and cohesively, and really engaging those grassroots one-man band organizations, because they are doing the work. I mean, some of the projects we talked about today, there's people who are two groups, one person doing the work, but they just don't have the funding. So it's about working together.
Delphine?
Similarly to Nana, greater funding for community-based projects that we know works.
Thanks, Delphine. Antonio, would you like to?
Oh, I was not expecting this to come to me.
You don't have to.
Yeah, you know what? One wish I'd say is just for everyone to keep striving for what we all want from our individual wishes. That would be my one. Is just never stop, never give up, and just keep striving, because where we might think we've reached a point of success, there's always still room for improvement.
Thanks very much, Antonio, and thanks. I wanted to thank everybody who's spoken today for your contributions. They've been really helpful, and I think given everybody a great deal of food for thought. And I think the comments in the chat really reflect how people have valued your thoughts. Notwithstanding that there is evidently still a long way to go, and I think Antonio's your point about continuing to strive is a really necessary one. So which actually sort of brings us on to the next steps. And I mean, this event is in the context of the inequalities work that we are supporting at Healthy London Partnership. But that should be taking place in each of your organisations, whether it's an NHS organisation through the integrated care systems and your constituent organisations, or whether it's within voluntary sector or local authorities or wherever you're working. We are working with senior leaders in each of the integrated care systems, children's mental health services, to think about inequalities from a strategic level, and we'll be having regular roundtables with senior leaders, but we're also supporting, and Natalie and I are the co-chairs for the inequalities working group. And I know some of you are members of that, and we, welcome new members if you want to contact us to get involved in that group, which will be supporting the strategic work that ICSs are undertaking. So this is, I don't think we've planned a specific follow-up event to this, but I think we're really interested in sharing learning and hearing from practitioners on the ground, and most importantly from the children, young people and parents that use services, because getting feedback from them and involving them in co-production, I think we've all heard, is a really vital part. In fact, we cannot achieve what we want to around addressing inequalities without a co-production approach. And apologies for my dog in the background. I think that we've now come to the end of the event. So thank you to everybody for attending. As I said, thank you to all of our speakers. I want to give a particular thanks to Antonio for being an excellent co-chair and for sharing your experiences at the outset, because I think that is a really important context. So thank you particularly to Antonio. So on that note, I'm going to close the event. So thank you very much.